First, Dr. Jessica Bloome, who is MD and PH, is the Deputy Director of SFDPH HIV Prevention CEBA Program and is an Assistant Professor of Medicine at UCSF. And also Dr. Demetre Daskalakis, MD and PH, who is the Deputy Commissioner, the Division of Disease Control, New York City, Department of Health and Human Hygiene. We ask that you will welcome them as they go throughout their presentations, and we will hear from Dr. Bloome first.
Great, thank you all so much for having me today. So I'd like to share lessons learned from the COVID-19 response in San Francisco. Next slide, please. So just a little bit of background about me. In my normal life, I provide HIV care to people living with HIV at Ward 86 Clinic in San Francisco. I also act as the Deputy Director for the Capacity Building Assistance Program for HIV Prevention at the San Francisco Department of Public Health. Next. And since March of this year, I've been working on the COVID response at the San Francisco Department of Public Health. And so I'd like to share some lessons learned from that work today. Next. I'm going to just give a little bit of background on the COVID-19 epidemic in San Francisco, and specifically the impact on the Latinx community here. And some of the lessons learned from the work that we've been doing, particularly around the HIV workforce and the COVID-19 response. Next. And I wanted to start out by framing this with the reality that I think many of us are aware of, that COVID-19 is bringing to light many of the historical and ongoing inequalities and racism in our society that were pre-existing. And in order to respond to this epidemic, we have to respond to the social determinants of health. Next. So a little bit of background about the COVID-19 epidemic in San Francisco. We did have a shelter-in-place order relatively early on compared to other parts of the country. You can see here that was mid-March. Next slide. And as a result, we thankfully have not been hit hard as compared to other cities like New York. And you can see here, although we've had our share of cases over the past month, we've been able to start to flatten the curve. And this data is as of last week. Next slide. But despite that, the Latinx community in our city has really been hit hard. And this is, I'm just sharing some of the data from the city as a whole. But the first figure here is a breakdown of people diagnosed with COVID-19 since the beginning of the epidemic by race and ethnicity. And you can see that 47% of people identified as Hispanic or Latinx. And that's among people who have a known reported race or ethnicity. And here at San Francisco General Hospital, where I work, 84% of the people hospitalized for COVID-19 were identified as Latinx. And just to give some context, about 40% of our hospital admissions on a general basis are people who identify as Latinx, and about 15% of the city's population as a whole identify as Hispanic or Latinx. So really, we just see a disproportionate number of people affected by active infection, as well as hospitalizations. And I think this reflects intersectional risk. Many people are essential workers. They cannot afford to work from home. They don't have the luxury of doing it because of the type of work they're doing. Many people live in housing conditions that put them at additional risk. People live in intergenerational households. They may live in crowded living conditions. Immigration and fears and worries about accessing resources that may be there for people at economic risk may not be accessed due to concerns about things like public charge. Many folks don't have access to healthcare, and that may put them at risk as well. And we see over half of the patients that we talk to with a COVID-19 diagnosis actually have no primary care that they were accessing prior to their diagnosis. Next slide. And this is just a map of the city looking at rates of COVID-19 diagnoses by neighborhood. And you can see that there's really a disproportionate impact in certain areas of the city. The areas in dark blue have over 50 cases per 10,000 residents, as compared to the areas in light green where only 5 to 10 cases per 10,000 residents have been identified. And the most highly impacted neighborhoods are have a few features in common. They're denser, have more people, but also have people at higher social and economic risk, and more essential workers. And in particular, I'd like to talk a little bit about the Mission District, which is the dark blue neighborhood highlighted in the middle, and has a high proportion of Latinx residents. Next slide. So the Mission has really been hit hard by COVID-19. And one of the responses in the city was the United in Health study, which is a study led by UCSF in partnership with the Latino Task Force for COVID-19, which is a community-based coalition, as well as the San Francisco Department of Public Health. And this study offered free community-based testing for residents of one census tract in the Mission District during a 4-day period in April of this year, as well as looking at, for people who are diagnosed, how do we connect them to services and care in a way that meets their needs. And in terms of the testing itself, it looked at both active infection, so looking at a swab or a PCR test, as well as blood testing or antibody testing to look for prior infection among participants in the study. Next slide. These were the main findings of the study. About 2.1% of community residents total. So among over 2,000 people, almost 3,000 people who either lived or worked in the community, which represented over half of community residents total, there was a 2.1% prevalence rate of active COVID-19 infection. And among people who actually work in the neighborhood, the prevalence rate was even higher at 6%. And I think that's just, again, an illustration that people who are essential workers are really at higher risk. Next. And this is a breakdown of race and ethnicity, both on the left, the pie chart represents people who were tested in the study, and on the right, there's a representation of people who tested positive. You can see there's a pretty diverse group who were tested on the left in terms of the breakdown, but on the right, the blue represents Hispanic or Latinx persons, and 95% of people who tested positive fell into that category. So really just another illustration of how this disease is disproportionately impacting this community. Next slide. The study also looked at positive PCR tests or active infection by socioeconomic risk. And 90% of the people who tested positive stated that they cannot work from home. 88% stated that they made less than $50,000 per year. And the vast majority of people who tested positive lived in a household with 3 people or more. So many of the people who tested positive are experiencing multiple risk factors here: their work, their household size, as well as economic risk. Next slide. I think to summarize all of this, what we're seeing in San Francisco reflects, I think, what we're seeing around the country and even around the world, that This disease does not affect everyone equally. And again, that we have to respond to the social determinants of health. Next. So coming from a background in HIV prevention, I was really curious to see how can we address this pandemic using what we know from HIV prevention, and also how can we take lessons learned back to HIV prevention work. Next. So one thing that struck me right away being deployed to the COVID response at our Department of Health is that HIV frontline workers have the skills that we need at this moment. They have skills like talking about stigmatized conditions like HIV and STDs. They work with marginalized populations. They have experience developing culturally responsive services and communicating with marginalized communities. They have experience with health counseling, even and especially when people have medical mistrust. We live the harm reduction approach in the way that we work. And importantly, the HIV prevention community has deep relationships with community-based organizations that are now at the center of the response. Next slide. And this is just an example of that. So this is a photo from our HIV Planning Council, and I think it's from 2011, so quite a ways back. And there's a few Department of Public Health folks in here who are HIV trainers or program coordinators, but most of the people in this picture are from community organizations or advocates in the fight to end HIV. So I think this is just an illustration of the deep relationships that exist. Next slide. Another thing that struck me in doing this work is that we are mobilizing people to the COVID-19 response who are HIV frontline workers, and they're taking leadership roles. So some of the examples of people who are joining this work in San Francisco Department of Public Health, we have test counselors, linkage navigators, PrEP navigators, DIS workers, as well as harm reduction counselors. And the two people I took their photo here are experienced health workers, and now they're leading the case and contact response in our COVID team. Next slide. And we also are deploying hundreds of people from all parts of the city government to help with this response, and many of whom don't have a lot of experience with these skills, and they have the opportunity to learn from our HIV workforce. Next slide. So I'm just going to go over a few examples of where we're using these skills and how we're deploying them. We're doing a lot of site visits and outreach to communities. So these are SRO buildings or crowded housing in the Mission District in San Francisco. And these photos are actually of workers at a community-based organization that we're partnering with to go out and provide education around COVID prevention strategies, as well as access to testing. And I think it's an illustration of using those partnerships and using those skills between our Department of Health and the community-based organizations. Next slide. We're also partnering with organizations that have a really deep relationship with specific communities. Here in San Francisco, the Yucatan Maya population has really been hit hard with COVID-19. And so the Asociación Maya has put together materials and been a real partner in working with that community. Next slide. Another crucial part of the COVID-19 response is helping people who need to isolate because they were tested positive for COVID-19 or need to quarantine because they were exposed to COVID-19 to do that safely and in a way that meets their needs and meets the need of their families and communities. So we call it a whatever it takes model, including a place to be safe. So we have alternative housing for people who cannot isolate or quarantine at home. food services, medicine, linkage to mental health and other services. And on the right here, we have our alternative housing or isolation hotels for people who need them. And breakdown of race and ethnicity shows that the Latinx community is one of the predominant groups who are using this resource. And I think it just illustrates that making sure that we have adequate wraparound resources is part of ensuring that our response uses an equity lens and make sure that everyone has access to be able to follow the guidelines and recommendations to protect themselves. Next slide. I also mentioned harm reduction services and how important that is in the HIV response and how we're using that with the COVID response. And this applies both in the setting of substance use disorder and helping meet people where they're at when they need to isolate and quarantine. And it also applies in terms of how we approach isolation for people who need to isolate because they have COVID-19. And looking at what is their personal risk, what is their community risk, and what can we do to support that and meet them where they're at. And on the right, there's a photo of a Safe Sleeping Village, which is an approach that the Department of Public Health has taken in partnership with community organizations to help people experiencing homelessness who cannot or don't want to enter hotels to safely space encampments to reduce their risk. Next slide. And finally, until we have a vaccine or cure for this disease, case investigation and contact tracing is really at the core of slowing transmission and effectively implementing mitigation for COVID-19. So making sure that we have all the steps in place, from disclosing the test result to helping people isolate at home to finding out about their close contacts so we can help them quarantine safely. All of that requires all of the skills that I mentioned earlier that we have learned from HIV prevention and the HIV response. Next slide. And this vision is really to accompany patients, link them to the support they need, and break the chains of transmission so that we can prevent disease and save lives. Next slide. So in addition to being able to use all the lessons that we've learned from HIV prevention to the COVID-19 pandemic, I think this is a huge opportunity to bring lessons learned from what we're doing now back to HIV prevention. When we have a disaster, we come together in new ways, and we have an opportunity to develop and strengthen relationships between public health, communities, and community-based organizations. I think we also have an opportunity to train a sustainable workforce for the future to address health inequities, including the HIV, hepatitis C, and STD epidemics. Next slide. So in summary, I really feel that the COVID-19 response is an opportunity to build on the skills of our HIV workforce that have been developed over years to address health inequities now and in the future. And we have quite a few challenges ahead. I think we need to focus on building communication between public health and community-based organizations. We need to recognize intersectionality and make sure that we're bringing anti-racism into our work. Likewise, we need to look at how do we support immigrant populations, knowing that our government is often part of the problem. And how do we think about sustainability? And I think now is a time to think about what is our vision for the future and how do we invest in a way that we can use this work to continue to fight health inequity. And finally, how do we empower the community, the most affected people and community organizations, to be leaders in this work as the experts in addressing social determinants of health? Next slide. So Thank you all for taking the time to listen. And I wanted to thank specifically Dr. Jonathan Fuchs at San Francisco Department of Health and the CEBA team, Monica Gandhi and the Word 86 team, and the San Francisco Department of Health COVID response team. Thank you all.
Thank you so much, Dr. Bloom. And unfortunately, Dr. Bloom has to go, but if you have questions for Dr. Bloom, please feel free to write them in the chat box, and we will be able to get those questions to her, and then we'll respond with the questions through email to everyone tomorrow and at a later date. So again, thank you, Dr. Bloom, for your presentation. And then we will go to Dr. Demetre Daskalakis, who will go into his presentation this afternoon. All right.
Great. Can you all hear me?
Yes, sir.
Great. Thank you very much. And thank you for including me in the virtual reunion Latina. So Sean, you're advancing slides for me? Great. Next slide. So I'll start with a little bit of a where are we now. So we're now over 3 months since our first confirmed case of COVID-19 in New York City. New York City has a story very different from San Francisco. We have over 200,000 confirmed cases and over 52,000 hospitalizations. When you look at our confirmed and probable COVID deaths, we have nearly 22,000 deaths. And in fact, we have the 7th highest number of deaths as compared to any country in the world. There, however, has been a sustained decline in case counts, hospitalizations, and deaths, showing that mitigation measures that included physical distancing are now working. It's really important as we are transitioning to the next phase, suppression, which I'm not going to talk a lot about, that we need to currently maintain the work that we're doing to continue our mitigation strategies so that we can move on to the next phase of our response. Next slide, please. So in terms of what we've done in response so far, and I'm not including a lot of the new innovations that have started now in New York City, very similar to San Francisco, that includes the Health and Hospitals Test and Trace program, which is very similar to the tracing program that was presented by San Francisco. But in the historical part of this pandemic, we have had enhanced disease surveillance to track disease spread, coming up with new and innovative ways to show what we're seeing in our jurisdiction. Significant amount of work educating the public through webinars, virtual town halls, social media, guidance documents, as well as media campaigns. Additionally, also guidance around specific disease states. So we released guidance specifically around HIV and STI, given the significant change in our care landscape during the surge of the pandemic. This guidance was provided to doctors, hospitals, nursing homes, and other healthcare facilities. And by guidance, I don't mean just paper, but also hands-on technical assistance in many of those scenarios. Laboratory testing began in New York City at the health department, but has since now become a citywide effort with significant amount of work to increase the capacity of testing both in public and private laboratories to be able to achieve the needs of significant testing to be able to better control the pandemic. Additionally, one of our very important roles in the response was really dealing with the effect of a surge of individuals coming into healthcare. So a lot of work, a lot of energy revolved around meeting increased healthcare needs. And now that meant this distribution of medical equipment and supplies. And by that, I mean ventilators as well as personal protective equipment. When we were in the deepest throes of the surge of the pandemic, given the very significant impact to supply chains that we encountered because of other parts of the world that were also suffering with this virus. Additionally, We worked to build volunteer and paid healthcare workforce. So we opened our medical reserve corps and increased it by a significant number of volunteers, and were able to provide staffing to hospitals who were in need, as well as paid healthcare workforce in scenarios that were necessary. Additionally, during the peak of the pandemic, we also had alternate care sites that were a collaboration between federal partners, state partners, in places like the Javits Center, and a couple of other locations throughout the city. We also worked to improve targeted diagnostic testing, and also have now done a lot of serology surveys, which means antibody testing. So I wish I had data to share with you. They're still chugging along, but soon we'll have more to say to you about serologic surveys in New York City. Additionally, a lot of work in planning for future phases of the pandemic with our partners at H&H, given our approach into the sort of later phases of the pandemic, the suppression phase, where contact tracing for us will become another dominant feature of our response, as you heard about in San Francisco. Next slide, please. So lots of highlights, and there's also a lot of challenges. We were successful in coordinating response between both New York City public and private hospital systems. That was a very significant part of our work. I can tell you that we distributed tens of millions of gloves, face masks, gowns, and other PPE. And actually, one of the most amazing pieces is seeing a citywide response that pulls out on agencies and talent that's not only at the Department of Health, because not only did we identify places to acquire PPE, but actually created local production of PPE in certain circumstances, specifically gowns and face shields that were being produced in New York City. Really a remarkable feat, and also a lesson with a lot of work happening in New York City to establish a 90-day surplus of personal protective equipment. So in the case of another surge or similar threats like COVID-19, we would be able to more easily be able to supply hospitals and other care providers and people in need. Additionally, as I said, we worked with our federal and state partners to build auxiliary medical sites. And so lots of work together across different pieces of government. We also had to, as everyone else has had to, reinvent traditional community outreach. A lot of you using Zoom, lots of Facebook Live and other platforms to make sure that we had connectivity, including the creation of a community advisory board that has been critical in guiding us through our work, especially as we transition into a period of more case investigation and contact tracing. Our response was multilingual, with many materials translated into over 20 languages. Additionally, another really important thing that we learned was that as we became a citywide response, and not only a Department of Health response, that there were really rich resources to better understand and predict transmission patterns, disease burden, death, and also risk of disease. And so we're still learning more and using these really great data sources, but it's been really fascinating to be able to tap into different strategies to describe the pandemic. Next slide, please. So the good news is that it appears as if the messaging that we had worked. So I think one of our very early messages with it was that New Yorkers should stay at home. And the effect was, this is only a example of a graphic. It's not our pandemic. I'll show you those in a moment. Was that we were able to flatten the curve. And at the moment are at a very, very good, in effect, the tail of the curve, we hope. Of course, resurgence is always possible. So I think one of the important lessons was that the faster you move, the better you do. And so I think looking back at San Francisco, I think they actually went into their shelter in place, which is similar to our pause, about a week before us. And so I think the combination of that, as well as our population density, really creates a different story in New York City from the perspective of numbers. But what you will see soon, it does not weave a new tale from the perspective of the groups who are already experiencing racism and the other impacts on the social determinants of health to result in very similar experiences, especially among Latino and Black New Yorkers. Next slide, please. So this is it's called our epidemiologic curve. And so you can see that we are definitely in a different place than we were in mid-April. Again, April 1st is a day that we will remember for a long time, April 6th as our peak of over 6,000 cases in one day. And you'll see that you can map what's happened to the pandemic. So our first move toward creating mitigation was when New York City schools were closed on the 16th. I believe that was around the same day as San Francisco went to shelter in place. You'll see that about 6 days later, New York City went into pause at 8 p.m. And what you see pretty consistently about this pandemic is that you don't really experience the benefit of your actions until 2 to 3 weeks after they're done. And so about 2 to 3 weeks after our pause, we started to see our numbers going down. And again, we continue to see these declines as New Yorkers work hard to adhere when possible to our advice. Next slide, please. So there's a lot of challenges, and one of them is readiness. So we have experienced systematic defunding and underfunding of public health. So over the last several years, federal funding for lots of New York City disease prevention and controls program has been reduced or even flat funded. And remember, when you're funded flat and there's inflation, that equals a cut. New York State cut part of our Article 6 funding in 2020, which resulted in a $59 million loss to the health department, which was partially replaced by New York City, but that was a significant blow. Elimination of $20 million Predict Pandemic Early Warning Program by the Trump administration nationwide also ends up not being something that was particularly helpful in detecting a pandemic. So this really leads to public health playing catch up. So we had insufficient staffing, surveillance systems that work, but really were in some ways archaic. And as we learned, depleted emergency stockpiles. And that's not a city or state issue. That's also a major federal issue. So not enough PPE, not enough ventilators at hand to be able to move quickly during a surge of patients. Next slide, please. Also, there was a lot of things that's shifted around what we've learned about the virus. So it's a new virus, and our understanding of prevention, transmission, and symptoms, care, and medical complications keeps changing. So we had different focus at the beginning with what symptoms were and learned more. So for instance, we learned a lot about people, for instance, losing their sense of smell and taste, which is not something that we had heard about until the virus landed to our shores. We also learned midway through the pandemic that asymptomatic transmission is more and more significant, something very different than what we understood at the beginning of the pandemic. And we still have things that are known, though it's unlikely. We don't really know if someone who's had COVID-19 before could potentially get it again in the future. We think that it probably does mean some level of immunity, but we can't tell you for how long or how complete. We also had significant issues in the way, I think everybody, in the way that the federal response rolled out. So we were sort of required by the federal government to have travel restrictions that focused on individuals who were returning from China. But all of the molecular epidemiologic data in New York City to date demonstrates that our introductions were likely from Europe. So we were in so many ways limited in terms of what we were able to see, because our testing was both limited in terms of what was available and also limited in terms of guidance that really focused us on actually the wrong population coming into the city. And so I think there are papers that exist and are coming to press that talk a lot about the different ways that that COVID-19 were introduced in the United States. Again, we also had a significant gap in testing. So both testing supplies, PPE, and medical equipment. And so again, this resulted in a large jurisdiction. Many decisions had to be based on resources and not best public health practice. Let me give you an example. The New York City Department of Health had to, at one point, recommend that all testing be limited to individuals admitted to the hospital because we didn't have swabs and we didn't have tests. And so ideally, what we should have done is say everybody in the world who's symptomatic should get tested. But because of that scarcity and because of the testing failure, we didn't have the ability to scale up in a way to be able to achieve what would have been optimal public health strategy. Next slide, please. Now, additionally, this has been the largest emergency response in New York City's history. I cannot tell you how many wonderful colleagues I have made during this, given the fact that I now talk to every city agency in the city. I know we have interactions with them usually, but in this scenario, literally everyone from the Parks Department to the NYPD to FDNY to like areas of the city I didn't even know they had agencies, we're all working together in a very, very efficient way. But it is a massive undertaking. Sometimes, however, we had this coordination between city and state. Sometimes we had conflicting mandates and guidance, and sometimes no advanced knowledge of policy changes, which made it a bit more complex for any of us to do our work. And by the advanced knowledge of policy changes, I'm specifically referring to a lot of things that came down from the federal government that shifted pretty quickly and sometimes without announcement. Additionally, we had some regular streams of misleading and false information. So again, working against it's going to disappear one day, it's like a miracle, it will disappear is really hard when you're trying to scale up response and increase awareness in a jurisdiction. Additionally, we were fighting against federal claims against benefits of unproven therapies, such as hydrochloroquine, ingesting disinfectant, and UV light. Really a challenging messaging time. And additionally, and in a very significant way, COVID has not taught us a new lesson. COVID has taught us a lesson that every infection that we deal with in New York City has taught us, including HIV, which is that infections capitalize on stigma, racism, the history of medical abuses, and immigration clients, and an immigration climate that creates government mistrust. Next slide, please. So it's a tale of two cities. And we have a tale of two cities within our city as well. This isn't about San Francisco and New York. New York has a story too. And I think San Francisco showed it so well, the certain various parts of the city with different experiences. And again, as I said, as with other infectious diseases, people of color, low income people, and people living in higher poverty neighborhoods account for a disproportionate share of COVID-19 cases, hospitalizations, and deaths. So the disparities relate to a lot of issues, and it could be multifactorial. But again, the core issue is structural racism, higher rates of pre-existing conditions, difficulties in practicing social distancing. So I think we heard from San Francisco, and we have a very similar experience that essential workers had to travel if they had frontline jobs. Individuals had smaller or more crowded, often multi-generational apartments, making it difficult to create space after a diagnosis. There's healthcare access issues and other social determinants of health. Next slide, please. So this shows our cases and hospitalizations, the rates by race and ethnicity. And so I'll tell you first, our most complete data for race and ethnicity is in hospitalizations and people who have died. Cases, we have limited information because of the way lab reporting works, but you can see that the cases story, it seems pretty similar to what we see with hospitalizations and deaths. So what you'll see again is that hospitalization rate increases among Latinos and Black and African Americans, as do cases. Again, demonstrating the same inequity that is seen both here and in San Francisco, as well as other parts of the country. Next slide, please. The same is true for probable deaths and confirmed deaths by race or ethnicity. So you can see that, again, similar to San Francisco, our Latino and Hispanic population experienced the highest number of confirmed and probable deaths. Next slide, please. And this is a tale of two cities that I'd like to show you. So very similar to the San Francisco view. This map, I could tell you, is the map of poverty, is a map of HIV, is a map of many other chronic diseases, including diabetes and hypertension for New York City. I could tell you that, but this is also our map for COVID. So the demonstrated effect of COVID is that it really does exactly what every other infection does. It goes to the parts of the city with people who are poorer, and specifically individuals who are Black or brown, demonstrating the ongoing inequity that is baked into New York as well as other parts of the country. Despite a lot of effort by a lot of people, these continue to be inequities that are challenging and continue to result in worse disease outcomes for people who are Black and brown, really sort of pushing the statement that we need to stop taking baby steps with with equity and instead take quantum leaps. And so I'm highlighting two areas in New York City: the Bronx, the neighborhoods of Allen, Baychester, Pelham Gardens, Williamsbridge, Bronx versus Greenwich Village and Soho, Manhattan. This is cases. And what you can see is the case count is much, much higher in the Bronx. The rate is almost 7 times higher in the Bronx than in this part of New York, in Greenwich Village and Soho. Positivity rate for testing in Lower Manhattan was about 14%, while it was almost 34% in the Bronx. They experienced 8 deaths in that neighborhood in Manhattan, while this neighborhood in the Bronx experienced 320. And our death rate was more than 10 times that in this neighborhood in the Bronx than in Greenwich Village. So really, again, we don't have to look at two cities to compare. New York City can compare to itself. And it is a tale of people of color and a tale of people who have economic and other social determinants of health that allow them resources to be safe versus others who do not. Next slide, please. So some lessons and opportunity. So COVID-19 has drawn attention to inherent weaknesses in the US that led to disease transmission: lack of paid sick leave, cost of healthcare, high un- and underinsurance rates, as well as what we've also heard from San Francisco, the public charge and other anti-immigration rules and sentiments that make it hard to trust the government and to trust healthcare. It has also shown a spotlight on the importance of sustained public health funding to rapidly detect and respond to disease outbreaks. We're grateful for all of the effort going into contact tracing and case investigations with our partners at H&H. What is really important is that when COVID-19 is contained, we must maintain a level of public health infrastructure to be able to respond quickly rather than having to build from scratch. We can also do better with technology and be smarter about our responses. So we need to work harder to have better surveillance rather than having us build systems from scratch during a pandemic. And we must really fight the true virus, which, though it appears to be COVID-19, I think that both San Francisco, my colleague, and I have convinced you that, in fact, it's racism that is the virus that is causing the most devastation in New York City. Next slide, please. Thank you very much. I'm able to stay for about 5 minutes for questions because I also have to pop off for another meeting. Sorry about that.
Thank you so much, Dr. Demetre Daskalakis, for your wealth of knowledge, and also to Dr. Jessica Bloom for your wealth of knowledge as it relates to the Tale of Two Cities. Now, if folks have any questions, because I do not see any in the chat box, feel free to write them in the chat box and I will ask them, and we will get a response from Dr. Daskalakis as well. And we'll wait a few minutes for folks who might be typing. Additionally, there will be an evaluation from today's session that will be emailed to you all after today, or later today and also tomorrow. So we have Dr. D, we have a message from Juliana Hiano that says, what is the biggest lesson learned?
I think my biggest lesson learned in the response is that racism is a public health emergency, and that we've been in that emergency for a very long time, and a lot of work seems to have gone in to try to address it, but it's not enough. And so I think that that's my lesson learned.
Yeah, thank you. You know, because as we're talking about what's happening in the world today as it relates to the extinguishing of Black lives, as it relates to police violence, and then the fact that, you know, Black folks are having to get back into the streets to choose between either their public health or their health and their humanity, right? We're noticing this as well. And then we also says from Luciano, who says, thank you to you, Dr. Demetre, for your information.
Thank you.
Are there any other questions? Okay. All right, so we have a question from Rebecca Weiler that says, are we seeing a spike in cases yet as a result of the protests that are happening in the city and nationwide?
Great question. So our surveillance system is looking very carefully at changes in the early warning metrics that we have. The ones that told us that COVID was landing, we're also making sure and watching it hourly to see if there's any change. So as I said on the slide that showed the story of the cases over months, what happens today, we tend to feel in a couple of weeks. So if we are to see increased COVID activity related to the very important protests in New York City, we would expect to see that in 2 to 3 weeks. With that said, I just wanted to make another comment about that, which is that though protesting outside in a group could potentially be risk for COVID, more of a risk is being arrested for COVID and being put into vans and buses that are overcrowded and then taking to central booking of some variety where you will potentially not have a mask. Also, I also am worried about seeing a lot of our frontline workers right now not wearing masks while they're responding. And so I think that I am more worried about that aspect than the actual outdoor piece of what's happening. Though I can't say that there's not risk, there is, but definitely the indoor transmission is way more likely than outdoor.
Thank you for that. You know, there were a lot of articles circulating between yesterday and today that says that there were an increase of, I think, about 21,000 coronavirus cases, and they were linking it to the recent protests. But now that you're saying that we won't see these for a few weeks, then we know that this article is, pretty much false.
Yeah, no, I think that that's probably false news. I mean, there are folks who have like a short incubation period between the time that they get sick, they get exposed and they get sick. But the middle phase of that's about 5 days. So I think it would be strange to see a surge immediately. I would expect, if there will be a surge, which hopefully there won't be, to expect to see it like in a couple of weeks.
All right. And we have a question from Elizabeth Marie Rivera that says, has there been any cases of discrimination based on orientation and or gender identity concerning COVID-19?
It's a great question. And it's one of those things that really speaks to improving our surveillance system. So we use lab surveillance, and we actually don't get gender identity in lab surveillance. And so why that's really important now as the Health and Hospitals Corporation is launching their TRACE program, those questions are a part of what they're doing. Additionally, we made sure that with the launch of our sero surveys, and those were the tests, the surveys looking at antibodies, we actually included gender, sex at birth, gender, as well as very complete information about sexual orientation, or questions about sexual orientation and race ethnicity. So I hope to be able to answer that question in the near future.
All right. Are there any other questions? Okay. So seeing that there are none, again, we thank you all for joining this session today on the tale of 2 cities about COVID-19 responses that was led by Dr. Jessica Bloome and Dr. Demetre Daskalakis. There will be an evaluation sent out today and tomorrow, and we ask that you all fill out those evaluations and give us your honest responses to today's session. Again, we ask that you enjoy the rest of your day. There are other sessions happening today, and be safe as we are still navigating uncertain waters. We ask that you be safe, and we wish health to you and your families. Thank you and have a good day.